All right, I'm going to go ahead and get started.
Yeah, I will listen.
Can I quickly get a show of hands? Like, how many of you were here for a presentation I gave like 2 weeks ago? You're going to like a good deal of recap material. Sorry. So my name is James Collins, for those of you who don't know me. This is the third presentation in this series on individual-based simulation models of public health. I gave part one of essentially the methodology overview a couple of weeks ago, and then Nathaniel Blairstein and Yongchen Z, where did Yongchen go? It's back there. They gave an application of our modeling techniques to small quantity lipid-based nutritional supplementation, which is when you go give kids a nutritional supplement in addition to their daily diet to essentially see if you can have any impact on child growth failure risks and iron deficiency. So I'm going to talk a bit about the simulation science team here. So I lead the engineering team on the simulation science team. And so we do public health modeling, just like many of you. In particular, we analyze the impacts of interventions on health systems in terms of disease burden, risk exposure, and healthcare costs. So we do this to give policy advice to decision makers. Our entire goal is to provide an agenda-free evidence base so that people who have to make really hard decisions have some information to make those decisions. They're trying to figure out what studies to fund and which intervention campaigns to roll out, things like that. And we do this all with computer simulations. Okay, so our agenda today. At the first session a couple of weeks ago, I talked about a bunch of things. I talked really broadly about simulation for about the first half of the simulation, or the first half of the presentation. I'm not going to go back through all of those things. I also gave a description of our modeling paradigm, which is discrete time, individual-based Monte Carlo simulations. I am going to go back through those things because I feel like if you miss that part, then the rest of this is really not going to make any sense at all. And then we started to pick apart a simple risk and cause model. We started going like depth first, and I'm going to instead this time take a broader view and try to give you a good idea of how the whole simulation gets initialized, how the whole simulation moves forward in time, and how things link up to each other. So part one, recap the modeling paradigm. Part two, we'll talk about the concept model diagram, which is our main modeling tool for describing what goes in our models. And without whatever time we have remaining, I'm going to give a demo of how to essentially start up a simulation and explore different pieces of it. Cool. So our modeling paradigm, individual-based discrete time Monte Carlo simulations. It's a bunch of words, and I find it easiest to understand in pictures. So some of you have seen this. Oh no. Some of you have seen this picture already. This is a cartoon of what a very simple Vivarium simulation might look like. What this does is it captures two aspects of our modeling paradigm. Namely, it's individual-based, so we simulate individual people inside of our population. And it's discrete time, which means time marches forward in like tiny chunks that we determine ahead of time. We can think about this, this paradigm in two different ways. One is we have this collection of individuals. I've represented them here by the little stick figures. They march forward in time, and sometimes they die. We only get to see what's happened to them after we've stopped to record what's going on in the simulation. This is the discrete nature of the simulation, and so we mark deaths in this simulation essentially on the discrete bits. So for instance, the person number 2 here looks like they died sometime in between time step 2 and time step 3, but I don't know anything about the between time of time step 2 and time step 3. And so when I come back to check at time step 3, they're dead, that's when they die. So this picture has limitations. And really the big limitation is that an individual can have many different attributes in addition to being alive or dead. They have an age, they have a blood pressure, a cholesterol level. They may or may not have access to clean water, and they may be sick with one or many different diseases. So the more useful representation of the population is here at the bottom. what we're trying to talk about is the state of the simulation, which is a representation of the entire population at a particular point in time. In our second representation, what we think of is a matrix or a table that represents our population. The rows of that table will represent individuals, and the columns will represent unique attributes of those individuals. So our table in this model would be very simple. There would be an index column that would label who the individuals are, and then a single column that tells me who's alive and who's dead. What the simulation does over the course of actually like running the thing is it produces a trajectory, which is simply a sequence of these simulation states. And what we care about is what the model is, because the model gives us the rule for how this state changes over time. So we're going to dive a little deeper and talk about how the model is responsible for altering the simulation state. So I find the easiest way to think about this is to think about a single time step. Notice that the little x here at the bottom below these things, I've zoomed in down to look at the picture of an individual. The reason why we do this is like our simulations typically don't have things like infectious disease dynamics, which is to say our individuals don't directly interact with each other. We may model certain things, like a thing we're talking about modeling now is household composition. And so people may live in the same household, but they don't ever talk directly to each other, which is a common modeling feature in other people who do individual-based models. Our focus instead is about heterogeneity at the individual level in the population. Our simulations tend to have many, many different attributes. And so an individual is composed of all these different disease states and all these different risk exposures. And it turns out sometimes it really actually does matter quite a bit when you're talking about the impacts of intervention about the individual level heterogeneity, and that's where we sort of specialize. So when we're looking at an individual time step then, I don't have to think about the whole population at once. I can think about a single individual, and I could think about a time step as essentially looping over all the individuals in my simulation and going one by one to them and saying, I have a series of decisions I have to make. For instance, do I die? Do I get sick? Do I visit a healthcare provider? Many other things. So what then is a decision? Simply put, it is the process that we use to ask and answer questions in the simulation. There are different kinds of questions we might ask. Some questions are deterministic. How much older do I get? Our simulation runs a discrete time, and so a person's age will increase by exactly the width of a time step, so long as they're alive. Other questions are a little bit more difficult. Does a person die on this, this time step? That's a question that we don't have a 100% certain answer to. What we do have is a bit of data. We have a question, and what we're going to do is we're going to use the Monte Carlo technique to turn that data and that question into a probability in order to generate an answer for us. So for those of you who aren't familiar with Monte Carlo sampling, it's relatively straightforward. It's just these things I've described. You start with a question and some data, and there is a hard part here of turning that question, that data, into a probability. But once you have the probability, the rest is just drawing a random number and sampling from that probability to give you an answer. This may still be a little unclear, so we're going to look at a concrete example. So the question of do I die in the next time step is an interesting one. And if we go, luckily, we're in a situation where lots and lots of very smart people have figured out how to ask this question in a mathematically precise way. So we go to our survival analysis textbooks, and we find the way to ask this question is to say, what is the probability that the time of my death is between now and the beginning of the next time step, given that I know the time of my death is after right now, which is to say I'm currently alive. And then we can go to the GPD, which has all of this rich data on mortality. And if we're careful about what we mean by mortality rate, we even get a nice equation for what the probability is here. Once we have the probability, we take a uniform random number between 0 and 1. If that uniform number is below our probability, we say, yes, you do die in this time step. Otherwise, we say no. And that's essentially it. That is Monte Carlo sampling in and it is at the heart of pretty much every stochastic decision we make in our simulation. It will happen many hundreds of thousands of times in a single simulation, but it's all exactly this procedure here. So to quickly recap, a simulation is a series of discrete time steps of a known size. Time step is a loop over all the individuals in the simulation. I go to each of those individuals and I make a series of decisions. And a decision is a process for asking and answering a question about what happens to an individual. Those questions may be deterministic or they may be stochastic. If they're stochastic, we'll use the Monte Carlo technique and some data to inform the outcome. This is probably a good time to stop and see if you guys have any questions so far. Great. So that was mostly a recap of the last time. What we're going to do now is we're going to take a close look at the concept model diagram. This is pretty much our primary modeling tool for describing public health models. And what it is essentially a depiction of the causal structure of the public health model. Not sure why that keeps happening. So here's a concept model diagram. What it describes is ischemic heart disease, body mass index, and their impact on mortality. These diagrams, they give a modular description of the various components in the model. And by components, we mean exactly, and approximately, the set of boxes we see here in the diagram. So what I'm going to do is I'm going to take a minute and I'm going to describe what we mean by components and what their responsibility are in the model. So each box in our concept model diagram will typically correspond to one or more model components. And there are a few key things to think about when you think about model components. The first is that components are going to be responsible for a very small set of attributes for each individual. Attributes are going to be things like the age and the sex of the individual, whether or not that person's alive, or whether they have a particular disease. The component that defines these attributes is going to be primarily responsible for three things. The first is that they're going to be responsible for initializing these attributes at the beginning of the simulation. This is a rather difficult problem, and we're going to talk about it in a little bit of detail here. But if we think back to our toy diagram of the simulation at the very beginning, we had this initial starting state x0. And the way to think about that state is all the attributes in the simulation, like there's some out there ethereal joint distribution of all the possible attributes that people can have. And what we have to do in order to initialize our simulation is sample from that big giant joint distribution and assign all the people. In practice, we typically construct the initial state piecemeal, and we'll talk through how that goes. The second responsibility that components have is they have to define the decisions that change the attributes that they're responsible for. Again, it's almost always easiest to think about this from the perspective of the individual. So when we look at the picture of the time step and that series of decisions that needed to be made, a component will be responsible for some subset of those decisions. It will define both what the decisions are and then the process for answering the questions that they create. And the last bit, components are responsible for defining their relationships to other attributes in the simulation. If we're very careful in the way that we think about structuring our models, this can usually be done at the level of thinking about these big high-level components, which is what lets us draw these handy causal diagrams in the first place. So with this framing, we're going to go back to our concept model diagram. And our first declaration about components is that they're responsible for modeling a small set of attributes. We see here I've labeled the attribute set each of these is responsible for. The population is going to be responsible for the age and sex of each individual. Mortality is going to tell me whether or not that person's currently alive, but also what their cause of death is. Ischemic heart disease is going to be responsible for modeling its own disease status, and then body mass index is, of course, responsible for body mass index. So if we think back to our description of the simulation state as this big matrix or table, this diagram is going to correspond to a table that looks something like this. Each one of these attributes is here in the table. We have rows representing all the individuals. I've got 5,000 of them. And they have the attributes we described: the age, the sex, that the population component is responsible, whether or not they're alive and their cause of death, their disease status, and their body mass index. So a good question to ask at this point is, how do we get these values? Like, I mentioned before that the initialization is one of the primary responsibilities of these components. And when we think about initializing the simulation, we think about doing it piecemeal. Each one of these components is going to get a piece of its, responsible for sampling a piece of this thing. And typically, the flow of initialization goes from the right-hand side of this model to the left-hand side, which is to say these attributes on the left-hand side are usually things I initialize first. I'm going to sample the age and sex distribution before I do pretty much anything else. And then I'll use information from things on the right to initialize things going left by using a series of conditional distributions. So for instance, this is the distribution of age and sex for people over 40 in Kenya in 2005. What the population component then does is it does some careful disaggregation of this data, and then it builds a distribution on top of it. So then we can sample age and sex from this distribution. And that lets us fill out these first couple of columns. We sample it 5,000 times, and then suddenly everybody's got an age and a sex. For the mortality component, we don't need to actually do anything complicated. We always start our simulations off with everybody alive, which means nobody has a cause of death either. So if we go back, the next thing we need to do is initialize the disease status. We go back to GBD again this time, except instead of for demography, we go back for disease prevalence. So this is a picture of the prevalence of ischemic heart disease in Kenya in 2005 for people over 40. The data I'm grabbing here is post-COMO, which for those of you in the know is the process that GBD uses to deal with comorbidities among many diseases. But post-COMO data has some issues, the first of which is it only lives at the cause level, which is to say this prevalence data tells me whether a person has IHD or they don't have IHD. And ischemic heart disease is made up of many, many different things, like angina, which is like you have chest pain, or you've just had a heart attack, a few other things, heart failure, which is the big catch-all for lots and lots of other things. But this data is not going to tell me any information about that. So the question you have to ask is this sufficient to initialize my model? And really the answer there is perhaps. It depends on the complexity of your model of ischemic heart disease and the assumptions that you're willing to make given the data that you've got. For right now, what we're going to do is we're going to assume that there are only two states. Either you're susceptible to ischemic heart disease or you haven't. Once we've made that assumption, we get to treat this data from GBD as a simple probability mass function. I pick an age and a sex, or I go to each individual. That individual has an age and a sex, which means that they're going to sit in one of these bins that corresponds to one of these bars. And so I'll have a single value for them that determines essentially their probability of having ischemic heart disease at the beginning of the simulation. We sample that number, and some proportion of the people end up with ischemic heart disease. That lets us do the disease status column. And essentially, we've constructed a reasonable joint distribution at this point of age, sex, living status, and disease status. We're working with a relatively simple model here. Can anybody think of situations where this process might break down? There are lots of them.
If you had two causes, for example, and you sample both of them and initialize the people independently, that might not correspond to the joint distribution between those causes.
Yeah, that's the biggest concern. So for those of you on Zoom, what Nathaniel said was if we had multiple diseases, this process, I'm essentially treating all the diseases independently. And there are situations where this is okay, right? So if I'm modeling ischemic heart disease and diarrheal diseases, I can probably safely pretend that the probability that somebody has one of those diseases is independent that they have the other one. If I'm doing something like tuberculosis and HIV, this is no longer a very safe assumption. And so you have to be, I mean, this is part of the art of simulation, right? You have to understand where these, where your procedures are going to break down, and then to think about like the assumptions that you're making and whether they're okay, whether they're going to break things or not. Typically, we can usually get away with treating all the diseases, at least for initialization, independently. And there are reasons for that that are related to the dynamical portion of the model, which we'll talk about in a bit. So our last bit here to deal with is body mass index. Risk exposure is a bit trickier than prevalence. So unlike prevalence, I don't have a single number for each individual. I have a rather complex distribution. This plot here is the BMI distribution only among 45-year-old men in 2005. It is the weighted sum of 13 other distributions for reasons that somebody knows. So the most difficult part, so however, like even though this is more complicated, the most difficult part is really just constructing this distribution. And given the fact that we're all sitting here looking at a plot of this distribution, you can assume that I figured out how to do that. Once we have the distribution, again, the process is the same. I essentially draw a random number to tell me where in this distribution I sit and assign a BMI associated with that. And that's our last column. Hooray. We've now constructed essentially the complete joint distribution of the initial population. And yes, Nathaniel, this is where I stop for questions.
Is that distribution going to be conditional on whether you have ischemic heart disease?
It's a good question. I have a note to ask you guys that question.
Okay.
Ask it. So well done. So according to what I just described, no. I slipped in an assumption here that says the body mass index distribution is conditioned only on your age and sex. Is that a good assumption? You asked the question.
I would think not.
Right. How bad is it? This is again, this comes back to the art of of building these simulations, right? You typically start out with some research question. I made an assumption here. It's a big assumption. Is it a bad assumption with respect to the research questions I need to ask?
But the idea
Drew says yes.
So let's assume that it's a listed risk factor, like one of the ones that's known to have support as a covariate for the GBD. Okay, so you know that there's a covariance. Now what do you do about it? I've told you the covariance, and I'll even tell you the slope of that covariance, right? So that you can pick it out by age and sex.
The slope of the covariance.
Meaning some estimate of the covariance. Could you do anything about it?
Yeah, we could do something about it. We typically have it. And the reason we typically have it is because it turns out not to be that bad of an assumption. And like I want to propose a reason why. So you might make the claim that people at the very start of the population with higher BMI are more likely to also be prevalent with IHD. That's very true. But you're looking at what you really care about is what is the distribution of BMI in the leftover population, because the leftover population is most of your population. And the distribution conditioned on not having IHD actually doesn't look that much different. And while our starting state is off by a bit, the rest of our model dynamics is driven by the relationship between BMI and the incidence rate of ischemic heart disease. And so slowly the model self-corrects over time. And so we do end up with errors. The size of those errors, as far as we can tell when we do our validation, has not been noticeable. And that's a criteria you have. Like you can always go with, I need to be methodologically correct and sound. And then you do empirical validations and you're like, maybe I don't need to be methodological, like maybe I just need to clearly state my assumptions and it's fine. And it's always careful. It's always about what your research questions are as to how important this assumption is. Any other questions? Yeah.
If you were modeling just a more prevalent disease with a similar covariate, have you done that?
I'm sorry.
Have you modeled a more prevalent disease with like some other sort of covariate that is also linked, where it wouldn't be as easy an assumption that the covariate is like the population without that disease is represented?
Yeah. And the way that ends up happening, so we will get some sort of measure of the covariance, and when we go back to a distribution like this, when we go back to a distribution like this, we won't actually construct this distribution. We'll construct the joint distribution of BMI and disease prevalence, or BMI and fasting plasma glucose, which is essentially the criteria for diabetes. And we can do some fancy pants math essentially to draw from a joint distribution of those two things and then sample them at the same time. So when that's necessary, we do actually do those things.
So I think the question is, when is it necessary? Like what?
When is it necessary?
Yeah.
Yeah, I mean, there's some good criteria here. Like here's a place where you might make a case. Like I'm not saying in this situation it's fair, because I haven't posed any research questions here. I'm saying given the research questions we have asked, it's typically not been important. The criteria that you might have for this is like the disease is chronic, right? It lasts forever, and the difference between the distributions among the prevalent people and the non-prevalent people is really big. Like you can make a case for the difference not being very large because most people don't get IHD until like quite late in their lives. We can look back essentially at the prevalence back here. The prevalence doesn't really get over even 5% until you're like in your 60s if you're a woman, and by that time the proportion of those people in the population is quite small. So really it's like you have a long-lived condition and the risk factor is tightly bound. Like it's not I have had a history of BMI that has led me to IHD. So like fasting plasma glucose would be an important one, right? Because it being high for a very short amount of time is going to have pretty dramatic impacts on your disease states, whereas people are overweight for a good portion of their life without it having strong negative impacts. So it's a hard question. It's really.
But I guess the good news is that the machinery is there to do a joint distribution.
Yeah. The complex problem is like, where do you get the data? Because GBD does not have data about many of these things, and so it's grabbing it from other places. So the second responsibility that components have is to describe how these attributes change over time. The way I've phrased this so far is that the components are responsible for asking and answering questions about how those attributes are supposed to change. So the population asks how much older than we get. We've described before, that's a fairly simple and trivial question to answer. The body mass index on the other side asks how much does my BMI change. This one is worth talking about. I'm going to briefly mention, and then we're going to ignore it for the rest of the time. With risk exposures, we make a fairly strong assumption about how exposure changes over time. The way we produced our initial BMI was essentially to generate a random number between 0 and 1 and use that to pull a value out of the BMI distribution. In our models, we assume that that number between 0 and 1 that we picked stays the same for the person forever. What this is saying is essentially we expect our population to stay ordered over time with respect to risk exposure. That's not to say that their body mass index doesn't change, but the only way that it does change is when the distribution itself changes, which happens as people age and as time goes by. This is, again, an assumption where you might go, that's a little crazy, or that doesn't make sense, or this is going to be wrong. But I would make the claim that this assumption is essentially saying that every person has the average age and time trend given their starting position in the BMI distribution. Like we have cohort data that says the entire distribution evolves over time in a particular way for a given cohort. And we say everybody's ordered, they stay in the same place here. And so the people, as the distribution like width changes and its mean changes, everybody experiences the average trajectory change over time. It's a little difficult to think about. Don't worry too much about it. It's a strong assumption. It's not necessarily a great one for all models, but it has worked out well for us so far. Okay, given that, what we're going to do with the rest of this is focus on the two sets of stochastic equations, because what I want to talk about mainly is how these things are all related to each other. So we have two sets of stochastic decisions to make, one about whether or not somebody dies, and one about whether or not somebody gets sick or gets well. How does their disease status change? And if we recall our original example, we have a procedure for this. And that procedure involves asking a question, forming a probability using some data, drawing a random number, and then using that to make the decision. The determining whether someone gets sick or gets better is essentially the same decision here, except with an incidence rate or a remission rate replacing mortality rate. And so then the thing that we want to focus on is what are these arrows about? How are the models connected to each other? This is the last responsibility that components have. They have to declare how they're related to other components in the simulation. So the ischemic heart disease has to say, hey, whether or not somebody dies and what they die of depends on whether or not that person has ischemic heart disease right now. And whether or not somebody gets ischemic heart disease, which is to say they probably have a heart attack, depends on what their BMI is currently. The way that these relationships actually work is if we look back here, they alter one of these inputs. The input that they alter is always this rate, this data that goes into our decision. And by altering that data, effectively what they're doing is they're reshaping the distribution of the time till something happens. So we're going to look at this concretely for these two things because, well, it's important. It is how the model works. This is going to be a little math and terminology heavy, so definitely stop me if you've got questions or if something doesn't make sense. So if we think about the situation where we have our demography model, right, and we don't have any other causes in our demography model, that demography model should still work. Like it should still produce the right counts of death over time given my starting population. It should put all those deaths in the right place. And what we do is we assume that the mortality rate for every individual is just the all-cause mortality rate. Because you can think about the all-cause mortality rate as the mean of a distribution. It is our best guess at what the mortality rate is for any individual in the simulation. So when we add a cause to the model, two things happen. The first is we go to all the people in the simulation and we say, instead of using the all-cause mortality rate as your best estimate, what we're going to do is we're going to say, take the all-cause mortality rate and subtract off the cause-specific mortality rate, which is the mortality rate due to a cause among the entire population. And then this gives us a quantity that we call the cause-deleted mortality rate. Then we go individual by individual, and we add back in excess mortality according to their state within a disease model. So if somebody has ischemic heart disease, they're going to experience additional mortality, here marked EMR, which stands for the excess mortality rate, which is not a totally true thing, but is fine for us. If they are not currently prevalent with ischemic heart disease, the excess mortality rate is 0 for them. And so they only experience the cause-deleted mortality rate. So what we've done here is we've added heterogeneity into our demography model. This is the way that I typically think about this thing. You add more components to the model, the overall structure, the means that you would get back out if I'm sampling things, should not change in the model. What changes is the explained variance. I'm saying I know some more things about mortality because I'm modeling ischemic heart disease. Now I'm going to be able to tell you additionally about death rates among people with ischemic heart disease and without it. And this neatly extends to multiple causes. Right. You can ask, Drew.
I don't have a question.
Cool.
No, the reason I was smiling is that the cause-specific mortality rate, if it has a slope to it, if the hazard rate has a slope, especially if that slope differs from the all-cause mortality rate, have you investigated modifications to those equations that account for the change in mortality rate over 5-year intervals? In other words, so these things do add for hazard rates. They don't add exactly for mortality rates, which are estimates of hazard rates over 5-year intervals.
Yeah.
And so there's some equations that sort of help with that a little bit.
Yeah, so the answer is no.
Okay.
The answer is we assume that the mortality rates that we get are the best estimates for the hazard rates, which is, again, sort of true, sort of not true. And there are like methodological tweaks that you can throw in to make things nicer.
It's just a methodological tweak.
Yeah. All right, does anybody else have questions? I'm gonna do the same thing with risks. Risks look scarier, just forewarning. So the primary way that risks impact like the primary outcomes of mortality and morbidity in our model is through the incidence rates of diseases. So just like our mortality model, in the absence of risk factors, like we should produce realistic models of the prevalence of disease, which means I run a simulation with only a disease model and only mortality, and I should get the right counts of diseases in that model. And what we do here is we say, I'm going to use an incidence rate, and it's going to be this I hat character, which represents the mean from GBD for that demographic bin. So this is our best estimate. There's no fancy terminology like all-cause mortality rate for incidence. It's all incidence rates. And then the thing on the right-hand side that we're talking, the left-hand side that we're talking about is also an incidence rate. So I'm sorry, notation. It's fun. So then we add a single risk to our model. And again, two things happen. At the population level, we go to this mean incidence rate, and we multiply it by 1 minus the population attributable fraction. For those of you not familiar, the population attributable fraction is a number between 0 and 1 that describes the proportion of incident cases that are due to a particular risk factor. It follows then that 1 minus the population attributable fraction is the proportion of cases not due to the risk factor. And so this quantity in the middle here, this one, iota times 1 minus half, is going to be our risk deleted incidence rate. It is the incidence rate experienced, it's going to be the incidence rate experienced by everyone in our model who is not exposed or whose exposure is at some theoretical minimum level with respect to a risk factor. We then go individual by individual and say, what is your exposure to this risk? And we multiply this risk deleted incidence rate by a relative risk that is a function of that exposure. And a relative risk is essentially exactly the thing that we're describing. It is the ratio of incidence among people who are not exposed to people at a particular exposure level. Other way around, sorry.
I'm just laughing because that was fast. Keep going.
Yeah, sorry. Again, combines nicely. Don't worry about the product symbols. This is just how it works. Excellent. This is the bulk of the material. I'm not going to move to a demo, but I want to stop for more questions. We've got them at this point. Yeah.
So I guess many of these things like mortality rates and paths are a function of a person's demography, specifically, I guess, like age.
Mm-hmm.
So do you use like kind of like the starting age or like the end age at like your time step or like the middle?
So when we evaluate these questions, it's always on a time step. So the way to think about what's happening is I'm sitting at a particular point in time and I'm asking the question, in the next span of time, will something happen? And so the answer to that question doesn't actually take place until I get to the next span of time. So I don't actually ask anything about the intermediate things. I'm evaluating questions at the point that I'm standing at now. So
Okay.
I'll start. Demo. So in this last section, I'm going to show you how we set up and run a simulation. And we'll see if we can explore some of these relationships between the components of the model that I just gave you math for, like plots are better, right? Plots are better, right? Oh, come on. So we're going to use this model, the one that we've just talked through. The first thing I want to talk about. So this is the like sort of modeling way that we talk about the research way that we talk about the models. It's a diagram, and it's a communication method. We also have these things called model specification files. These are the top level interface to Vivarium simulations, and they mirror very, very closely what these diagrams look like. There is a component for each one of the things that was in that diagram. This is like really important for those of you who write software. You got to build things that people understand from their own language. The second section of our model specification is this configuration block, which tells us we're going to run in Kenya. We're going to use input draws 0. For those of you not familiar with draws in GPD, GPD produces all of its estimates in blocks of 1,000 draws. We're going to say we're going to get the first one of those, and we're going to use it. We're going to run our simulation from 2010 to 2015. There's implied like a July 2nd start date somewhere in here. And we're going to take step sizes of 28 days. Our initial population is going to be a group of people between 40 and 100, and we're going to start with 5,000 people. So what I'm going to do now is I'm going to drop out of this presentation and switch to the notebook and write some code. And you guys can ask questions. I'll try to write code to answer those questions, which should be fun. So let me see how I can get out of this. Bear with me for 1 second. Okay. Let's see. This is the smoothest that using like Jupyter Notebook presentations has ever gone for me. It's quite wonderful. This. Tilly, are you still on the Zoom thing? Can you see the screen? Okay, this screen is too small. Great. All right, I've written no code, so we're going to go for it. Here's some boilerplate to import some standard libraries. Here's a bit of HTML so to make the pandas tables not small. Okay, so what I'm going to do then is I'm going to import some stuff, and we're going to set up a simulation. So we have Vivarium is just a Python library that you can pip install. Yeah, I want to share my screen or split my screen in a way that I can see it on my screen and not have to look up there. Sorry. Still. No.
I
1 second. Stop sharing. So Vivarium has an interface module, interface import, and then we have all these nice methods that let us set up simulations from various different contexts. I'm also going to until I cheated a little bit. I wrote some code and stuck it in the module. Okay, so this util has the path to disease model specification that I'm going to use here. So I'm going to go, my sim is visualize. So that's going to make a simulation that is in what we call the initialized state. I'm still in a position where I can add and remove components here and alter the configuration, which is good for me because the simulation doesn't currently know where its data lives yet. So the first thing I'm going to do is just tell it where to find the input data. And then I'm going to set up my simulation. And what it's doing is taking that file that we looked through, and it's going to find all the Python components that are described there and the configuration. It's mashing it all together, and it's setting up the simulation. It's doing all the initial sampling of the population as well right now, and we'll be able to look at a population here in a second. This process does take a bit of time, mainly due to that BMI distribution that I talked about before. It is a big, hairy ensemble distribution of multiple risk factors. And the parameterization that GPT provides is means and standard deviations. And the way that it describes its ensemble distributions is like optimizations on top of those things to figure out the parameters. It's quite wild. Not this long. Okay. So the first thing we should always do when looking at a simulation is look at the initial population. And we can look at it a couple ways. Pop that head. Look at the first 10 rows. And what we'll see here is this looks pretty similar to that table that I described before, except there's a bunch more columns, because it turns out when you actually do these things are more complicated than that. And other things like we just want to be able to observe, which is I want to know not just like that you died and your cause of death, but I want to know when you left the simulation, for instance. That's useful information. Other things here, we'll track years of life lost. We'll actually track entrances and exits for individuals between different disease states, which is useful for calculating all sorts of rates of interest. And we initialize like an initial disease time for those people who start out prevalent, which is other more fun stuff. So I think I have a util. We can also look at the age-sex distribution of our initial population. This is a good way to validate. I showed you the actual data before. If you can't tell the difference here, I did my job. But these are the sort of trivial things. So a sort of thing that might be interesting here is like, what is the relationship between ischemic heart disease incidence rates and a person's age and sex, for instance. And it's fairly straightforward to get those things. So I'm going to stack everything up in my population data frame, even attributes I have to get from other places, just so I can do nice plotting stuff. So some values we store in these things called pipelines, and this makes it really easy to compose the function essentially that transforms the rate. We looked at the relationship between risks and incidence rates, and it was that big hairy equation with all the paths and all the relative risks. And so we had to build an abstraction on our side to make sure that wasn't an awful thing to actually write down in code. Index. Which is why it doesn't just look in the state table. Then we want to do here. Hope it's big enough for you guys. So we're going to plot on the x-axis age, on the y-axis the IHD incidence rate that we just gathered. We are going to color the points by sex. We're going to say data is our pop. And so we end up with a group like this. So again, our x-axis is age. So ischemic heart disease incidence rates go up over time. Good. There's a lot of heterogeneity in there, and all that heterogeneity is due to BMI distributions. So all the different people have all different kinds of BMIs. You see something looks a little crazy in the 50 to 60. And what that indicates to me, like if I had to guess at this point, it's that there's a really big wide distribution of BMI in this group, or we mess something up. But my suspicion is probably this is what GBD actually thinks the BMI distribution among 50 to 60-year-olds looks like. But that's also a question we can answer. So we'll do the same thing here, and we'll grab the BMI.
What was the relationship between BMI and IHD that you're thinking? Because that's the plot of IHD, but you're saying that's.
So this is the plot of IHD and age. So based on the structure of the model that we had before, right? If I've only got the disease in here, there should be no heterogeneity within a particular demographic band, right? I know I only have one risk in this model, so all heterogeneity has to be due to like differences in BMI among the subgroups. Does that make sense? Ask again in a different way.
What heterogeneity are you talking about?
So I'm saying, like, if I didn't have a risk factor in this model, I would expect for every 5-year bin for each one of these blue, yellow people, I would have totally flat lines. Everybody would have exactly the same incidence rate. Because my best guess is the average incidence rate. And so I assign it to everybody. When I add BMI in the model, everybody gets a different BMI based on their age and sex. And so now when I go ask what their incidence rate is, I go ask their incidence rate given their BMI value. And BMI is a continuous thing, right? So now I have all this extra up and down noise.
So what do you mean by an incidence rate? Because if I'm an individual, I either have it or I don't.
What do you mean?
So each one of these points is a simulant?
It is the hazard rate, the incidence hazard for IHD that individual is experiencing on this time step.
And then at what point do I get IHD if my incidence rate is above?
So it's not to do with your incidence rate. If we I can actually just scroll back up. So it's back in this graph, right? So this is the one for mortality, but the one for getting a disease is exactly the same, except instead of feeding in the mortality rate here, I feed in the incidence rate. And so every single time step, I'm going to make a decision. If you're not sick right now, do you get sick?
Right.
Right. And I use whatever the current incidence rate is. I compute this probability, which is just a number, right?
Right.
And then I draw a random number, and you either get it or you don't. So nobody deterministically gets ischemic heart disease. The rate changes over time, and every time step, I make a decision about whether or not they get ischemic heart disease based on their current rate.
But a higher current rate is more likely to.
A higher current rate is more likely, yes.
And so, at what rate would I have? Like, where in that figure would you say anyone above this has IHD or anyone? So
they're totally disconnected from each other. Maybe it's easier to think about this in like infectious disease land, where you have like very, very high incidence rates for things, where people will get diseases frequently. What a high incidence rate corresponds to is like the time till I get the disease, or the time till I die, or the time till whatever happens is shorter for me, right? But on average, but I'm not using the average. I am making a stochastic draw. I'm using some randomness. So somebody even like exposed to a whole world of risk factors might just be really lucky and like might never have a heart attack.
Yeah. I'm just trying to reconcile your use of the term incidence rate with the sort of epidemiological use of the term incidence rate. It seems like you're using it to mean.
I'm using it to mean a hazard rate. So it is the limit as I go to a very small chunk of time that says how likely in this chunk of time are you to get.
If you looked at his output and you did like a Kaplan-Meier estimator, you should come up with the same hazard rate. So it should, if you took his stuff and you took the sum of the events divided by the person years lived on where you're susceptible to those events, then the count of events, the count of those dots that fire should still correspond.
I think Everett, back in the back here, tried to do Kaplan-Meier analysis when I first showed up. Did you ever get anywhere?
I think we talked about it, but never did it actually.
It seems like a useful thing to get to at some point.
You've been able to verify, I think, that the counts match the GBD.
Yeah,
A
so
more internal verification would be seeing that the Kaplan-Meier rates match the GBD rates instead of looking at the counts.
yes, yeah, that makes a lot of sense. I don't know. We do a funny like jig on the way through. Like I go to GBD and I get the all-cause mortality rate, the cause-specific mortality rate, and then I go, I'm assuming these are hazards, right? And then we use them as hazards in the simulation. But then on the out, right? I compute a cause-specific mortality, but now I'm thinking of it like GBD does. It is the count of deaths in some span of time over some in some demographic group. In that comparison, which.
So what you're showing is the probability that a simulant would get IHD during that time step.
So what I'm showing you is the rate. Sorry, going back down here. So the probability is going to be 1 minus e raised to the power of minus whatever this thing is times the size of the time step, which is going to be some pretty small number, right? It's going to be some pretty small number on every time step, but then I'm going to take another time step, another time step, another time step. And on average, people who are at high risk probably will get IHD much sooner than people who are not at high risk. But that's not guaranteed. Okay. Any other questions? Yeah.
So I see at every sort of 5-year interval, there are like jumps in the distribution because we have estimates by 5-year intervals. Do you do anything to smooth out the estimates of the hazard rates?
We used to do a really dumb interpolation thing that made us wrong most of the time. We are looking at some other ways of doing this currently. Like DisMod sort of does this in its own model, but there are
The piecewise is a standard approach.
Yeah.
It is a well understood approach to this. And so I know it doesn't look good to the eye, but you know that your totals are gonna match. You could draw a really nice line through those things and get complicated. But the thing that I've never seen done is draw the line such that the survival analysis on the way in matches your data.
It's a very hard problem.
Yeah, it's a hard problem.
Right, because you think about like all the systems, like everything's been like this. So remember that like a individual incidence rate, there's only one risk factor in here. So my individual incidence rate is made up of 3 quantities that I'm pulling from GPD that are all been the same way. They're not the same kind of thing. One's a rate, one's a probability, and one's a ratio of probabilities. And so it's not even clear is the way to like interpolate or smooth those things the same, because no, it's not. And then how do you go about making all that coherent, right? Because I've got this big long model in which there's inputs on one side and there's outputs on the other side, and like something like interpolation is going to be it's a big deal to make it work correctly. Drew's never seen it apparently.
There's one disaggregation paper that addresses survival rates that I've seen, but that's only one. I've never seen it used.
Yeah. I'm gonna give it a shot. All right, I'm gonna look at how much time do we have left? Lost a clock.
We're over time.
We're over time. I'm
4:30.
done. It's what?
4:30.
So I'm gonna keep doing these not on a pace of every other week, but the next set of things that I'm gonna do is essentially deep dives into individual pieces of this model. Like, how do we actually sample a population distribution that's realistic, but also comes from GBD? It's not a trivial problem, and we'll go through things like that, cost models, risk models.